Hello, and thank you for joining me here at the American Society of Clinical Oncology meeting 2016 in Chicago. My name is Srdan Verstovsek. I am the professor in the Leukemia Department at MD Anderson Cancer Center in Houston, Texas. I'm going to briefly review the highlights of the CLL and lymphoma parts that were presented here at the meeting, with several of reports deserving to be mentioned in particular. The first one that I'd like to talk about is Venetoclax, which was tested in relapsed refractory CLL patients after ibrutinib or idelalisib. This is an important area because outcome of patients after these targeted agents is rather poor, and novel approaches are necessary. As we know, Venetoclax was FDA approved for patients with CLL with the lesion 17 and one or more prior therapy. In this pilot study, which was a two-arm phase 2 study, patients previously treated with ibrutinib, and almost everybody was exposed to ibrutinib before, of which about 60% were refractory, and about a quarter of the patients were also treated with idelalisib in the past. The Venetoclax introduction produced important results. Overall response rate was about 60 to 70% in prior exposure to ibrutinib, and about 30 to 40% in patients prior exposure to idelalisib. Most important part is that the therapy was very effective in about half of the patients that were in fact refractory to ibrutinib, and this is the main message of this abstract. The overall duration of therapy was about a year, and some patients indeed had even achieved complete remission with MRD negativity. This is a pilot study that deserves to be explored more. The only side effect of importance was hematological, which result in some interruptions and dose adjustments, but without any new discoveries in terms of the toxicities. So continuous therapy and extended follow-up is needed to fully understand the benefit of Venetoclax in this setting. The next highlight is of acalabrutinib, a second-generation Bruton tyrosine kinase inhibitor, which was tested in the previously untreated patients with CLL. Here, the results were presented in first 74 patients, where the medications was very active. Overall response rate was 96%. This is a study that is still underway. The toxicity profile was as expected, with lymphocytosis at the beginning, without any other major problems during the therapy. But the time on the study is rather short, and this study needs to be followed further. However, because of such a high overall response rate, a phase 3 trial of this medication, acalabrutinib, is being planned in a very near future in this patient population. We then move on to use of Lenalidomide in recurrent CNS lymphoma. Just briefly to say that because it is very well known that Lenalidomide has activity against lymphoma, and cereblon, which is the target for Lenalidomide, is highly expressed in primary CNS lymphoma, there was obvious need to and the desire to test Lenalidomide in this patient group. This is again a very small pilot study in about 14 patients where there was a significant activity in about 9 evaluable patients out of 13 with a decent response, which gives us an impetus for further assessment of Lenalidomide as single agent in patients with primary recurrent CNS lymphoma. Obviously, Lenalidomide does penetrate CSF, has minimal toxicity. We know this drug very well, and the recommended starting dose is 50 milligrams a day. This requires further exploration, but it's very exciting discovery. The last highlight is of a new medication called Megalisma, which is a monoclonal antibody which enhances antibody-dependent cellular cytotoxicity through CCR4, which is expressed protein on more than 90% patients with ATL. ATL is a rare malignancy of T cells infected with human T-cell lymphotropic virus type 1. There is no approved therapy for this condition outside of Japan, and this antibody was tested in open-label multinational phase 2 randomized trial, comparing it to investigational choice. and the medication was effective. It was safe. This is something that needs to be pursued in other parts of the world other than Japan. The 34% response rate was satisfactory. Duration response about 5 to 6 months with decent safety program. These are the highlights that I would like to mention at the moment. We follow up on the others and further follow up on these highlights. Thank you very much. Until the next year from windy Chicago.